In the Swift Prime trial, the stent retriever device was very safe. The rate of bleeding in the brain in patients who got the stent retriever that was symptomatic was only in 1% of patients, and it was no higher. Actually, it was 3% if you got TPA only, and only 1% if you got the stent retriever in addition. There was very low rate of subarachnoid hemorrhage and very low rates of other complications. So another major advantage of the stent retrievers are they are much safer than prior generation devices, both more effective in opening the artery and much gentler so that the artery isn't injured. In Swift Prime, the number needed to treat was 1 out of every 2.5 patients had a better outcome, and 1 out of every 4 patients had an independent outcome as a result of treatment. That's a spectacular impact. And for patients, this means they need to get to the hospital right away. We now not only have TPA, but we have embolectomy as a treatment option for them. There's more we can do for them, so they should know the warning signs, the FAST, face drooping, arm weakness, speech difficulty, any of those present. It's time to call 911 and get to the hospital right away. To the extent that we've looked at different subgroups, the therapies so far have been found beneficial at every subgroup that we looked at. In Swift Prime, whether you're a male or female, whether you were arriving later or earlier within the 6-hour window, whether you had a severe stroke or a moderate stroke, whether you got TPA in an outside hospital or TPA at the study hospital, all those patients benefited from the therapy. This is such an overwhelming benefit that likely anyone arriving with the right target clot in the right time frame is going to have benefit from this therapy. Well, the stent retrievers are an intervention that takes place in specialized facilities, in neurocatheter laboratories, and by specialized doctors who've been trained to do neurointervention. So this is not going to be a frontline treatment that every doctor in every small hospital throughout the country is going to be doing. This is going to be therapy done at comprehensive stroke centers, and we're going to need to have more of those. We currently have about 75 comprehensive stroke centers in the US. We need about 200 to 300. And we also are going to need to change how we route ambulance patients so that patients who need this type of therapy are brought to comprehensive stroke centers where they can get it. It's going to take some evolution of our pre-hospital system, but we already have 1,500 primary stroke centers and 75 comprehensive stroke centers out there. So it's more just refinement and retooling of the system. We should be able to get access to this very effective therapy for almost all Americans. Comprehensive stroke centers only started being certified a couple of years ago, and even without this proven therapy, when there was less justification for them, we were able to get 75 certified. We anticipate now that there's this new driver that this will crystallize many more hospitals that are close to being certified to go ahead and take that extra step, and that we will very quickly reach the target of 200 to 300. Many hospitals are very close to being comprehensive stroke centers. To meet that classification, you need to have sophisticated neurointensive care. You need to have neurosurgery available around the clock that is stroke specialized. You need to have the neurocath lab. And many hospitals will have this already available. It may be only weekdays or only 80 to 90% of the time. They need to change their staffing and put in a little bit of extra resources to be able to get up to 100%. So if we push those over the line, then we'll get there very quickly. One thing that will be happening, I expect, is that new guidelines will be written in response to these positive trials, and that will help shape a new standard of care. We will change the regionalization of stroke care in the US in order to bring more patients to facilities that can deliver this therapy. And then we need to look at the benefits of this therapy in later time windows. The studies today, including Swift Prime, looked essentially at the under 6-hour patients and showed overwhelming benefit. We know that at some point, 24, 36 hours, it's not going to be beneficial. The strokes will be completed. We need to look beyond 6 hours, at 8, 10, 12, 14 hours, and use sophisticated imaging to identify which patients in later time frames might benefit from this intervention.